Thank you so much for having me today. I'd like to start by acknowledging the traditional custodians of the lands from which all of the participants are joining today. I'd like to pay my respects to elders past, present, and emerging. And I'd like to extend that respect to all Aboriginal and Torres Strait Islander people who are with us here today. So in this talk, we're going to do it in 5 parts. I'm going to review digital health. I mean, that's our kind of starting point, and that's where we come from, and then move to the world of AI. And examine AI specifically in clinical decision support. We'll discuss challenges and then examine effects of AI on human performance, and then finally conclude. So we're in the middle of a pandemic, no matter where you're kind of joining from, and our health systems are facing enormous challenges. This was a list of priorities that were released by the WHO early last year, and it's noteworthy to see that even before the pandemic kind of unfolded, the Director General of the WHO said that a pandemic could bring economies and nations to their knees. And indeed, we're sort of seeing that play out before our very eyes. But beyond the immediate kind of pandemic, there's a lot of other challenges which are listed here. The climate debate, delivering health and conflict and crisis, making sure healthcare is fairer, improving access to medicines, stopping infectious diseases, preparing for epidemics, protecting people from dangerous products, investing in the very people who defend our health, and then keeping adolescents kind of safe. So, it's against kind of this background that we look at digital health and AI. And the hope is that, by with better use of technology, we can address some of these problems that our health systems are facing. So if you look at kind of digital health, we see that if we kind of move to digital health, we basically kind of see that we have, we're using digital health in our health systems to support a range of kind of decision making, a range of tasks. Decision making is one of the most important aspects. We're using digital health for messaging and record keeping as well. So it's being used by right across the health system, from hospitals to primary care, and right in the hands of patients as well. And so we're very well, I mean, I'm sure the network, the e-health network that people are joining from are very kind of up to date on digital health technologies themselves. And so it's against this background that we're kind of looking at artificial intelligence. So if we consider artificial intelligence, we've sort of seen this emerge in the last few years. We've witnessed, it's not really the emergence, but rather the re-emergence of artificial intelligence. It's essentially about teaching computers to do what humans do better. And in healthcare, a major application for AI is clinical decision support. We're using these systems for recognition, reasoning, and learning tasks. The major focus so far has been on machine learning algorithms, which make inferences from data. So you may very well have heard of neural networks, which mimic essentially the operations of a human brain to recognize relationships between vast amounts of data. And deep learning, is essentially the same idea with many, many layers, where the neural networks are many, many layers deep. Radiology has emerged as one of the 4 significant uses of deep learning, where some algorithms, the same algorithms that you can tell a cat from a dog, are now being used to identify tumors, tuberculosis, and heart disease in medical images. But as with any kind of method that you might have, deep learning too will have its limitations. So we know that it's not going to be suitable for all kinds of decision-making problems. So in health, really, AI in health is essentially machine learning plus a whole bunch of other reasoning methods. And it's about appropriately applying these methods to the problem at hand. So we think that there's a potential to solve some of these real intractable problems in the quality and safety of care. An area that has kind of emerged and there is a lot of interest is precision medicine. So the idea here is to essentially harness the vast amounts of data that we are collecting in our health systems to better inform treatment decisions. So this diagram here was published a couple of years ago now. Eric Topol, if you've read him, I mean, he's talked a lot about AI in healthcare. But essentially, what we are trying to do is when we're trying to use AI in decision making, essentially what we are doing is so let me just kind of go back one step. So essentially, we're kind of using AI for diagnosis, therapy, critiquing, planning, prescribing, information retrieval, and reminders as well. But essentially what we are doing when we're introducing AI for clinical decision support is we're supporting human information processing. So let's just kind of try to take a look at that a little bit. So as a human, when we process information, we basically sense, we perceive that information in our murky working memory. We then kind of arrive at a whole bunch of decisions that could possibly be made, and then the final stage is where we then implement that decision. So if I kind of think of a simple example is if you were kind of trying to decide whether you're going to drive to work or catch public transport, you kind of look out the window, you look to see or you look at your app, which is going to tell you, is it going to rain? Is it going to be hot today? And so you kind of sense and perceive the information that is available out there, and then you then reach that there's three options here where decisions you process possible three options that you might take, and depending on what you perceive the weather to be, you might decide, well, I might actually take a ride on the bike because it's really good weather today. So in a similar way, when we are kind of using AI in clinical decision support, we can automate each of these stages of information processing. So you can automate the acquisition of information. So you can apply machine learning to process vast amounts of data that is being acquired. You can then analyze that same information and then use it to assemble a whole bunch of decisions and then even act on those decisions. And I'm going to kind of explain this a little bit more in the next couple of slides using some examples. So essentially what we're trying to do when we're introducing AI into decision making is we are essentially automating the processing of information. We're using machine learning, which is kind of the dominant method today to automate the processing of this information. So based on that, what are the opportunities for AI in clinical decision support today? So there's a vast amount of systems that are being developed and deployed and being trialed as well. And one area which is kind of like a nice contained territory to kind of look at this is medical devices. Because all medical devices which are based on AI are essentially registered with a regulator. And so what we did was we kind of did a review of the devices that are currently kind of registered with the TGA. So this is a paper that we kind of published earlier this year. We essentially looked at 49 machine learning based medical devices that were registered with the TGA. So it's a kind of a painstaking process to identify these devices. And we identified 49 of them, and we found that about 35 of them were for diagnostic tasks and 10 were for triage tasks, and the remaining for a whole bunch of other tasks. We found that essentially these systems provide clinicians with information to support their decisions. In a small subset, they do provide decisions as well, but overall there is limited autonomy whereby they essentially require clinicians to confirm the information that they're providing, and they require clinicians to also be responsible for decisions. So we found that depending on the amount of automation, you could classify them into kind of 3 levels of autonomy. So the very basic level is where AI provides information for humans to make decisions. So the example here I've got on this screen is AI RAD. It's a Siemens kind of system. And essentially what this AI system is doing is that it's looking at CT images, and then it's providing quantification of lungs, lung lobes, and specified lung lesions. So essentially, it's providing information to for clinicians to kind of make decisions. There is a clear separation between what the device does and what the clinician does. And how they contribute to a particular activity or a decision. So another example in this class could be an ECG system that monitors heart activity. It interprets results and then provides information such as quantifying heart rhythm, which clinicians can then use to inform decisions on diagnosis and treatment. So that's kind of the very basic level of autonomy where AI provides information for humans to make decisions. The next level up is where AI assists humans to make decisions. So I have two examples here. And the main thing to kind of highlight here is there's actually an overlap between what the device and the clinician does. And so, for instance, both the clinician and the AI are responsible for the decisions. And if you're looking at the examples here, so the first one is cardiologs. It's an AI system that looks at ECGs and it identifies and labels abnormal cardiac rhythms. The second example there is called OsteoDetect. It provides a case level finding of disease. So it's essentially a software which is designed to assist clinicians in detecting fractures of the wrists. And it's very, very clear in this kind of system that clinicians mustn't use the CAD generated output as the primary kind of interpretation. They're actually responsible, the responsibility for the final decision on device tasks actually resides with the clinician. So there's actually an overlap here between what the device is doing and the clinician is doing. Another example in this class is breast cancer screening, where both the clinician and the device identify possible breast cancers. However, the clinicians are responsible for making decisions on what should be followed up, and therefore they must decide whether they agree with what the AI has marked up or not. So that's kind of the second level of autonomy, characterized by the fact that AI is assisting in human decisions. The next level up is an autonomous kind of system where the AI provides the decision on the clinical task, and that the clinician can then act on that on that task itself, on that decision itself. The example presented in this picture is called IDXDR. It's a diabetic screening system in the US that can detect diabetic retinopathy. So GPs so general practitioners or primary care doctors can essentially act on positive findings and refer those patients to specialists for diagnosis and treatment. And so they don't need to have the skills to interpret the retina photograph themselves. So the idea here is that these kind of systems, they provide a service that may not have been previously been able to be provided. And so the AI provides the decision, and the clinician then on the task, and then the clinician basically enacts that decision provided by the device. So we've kind of seen that there's 3 levels of autonomy, whereby the AI is either providing information, it's assisting in making decisions, or it's acting in place of the humans, where it's actually providing the decision themselves. The main kind of thing that we've seen here is that now we're starting to see more and more systems being trialed in clinical practice, and so you end up with this issue of the last mile, where we're facing complex challenges at the last mile of implementation, because when we have really well performing systems, they need to then go on to impact decision making and care delivery to measure some kind of effect on outcomes. So let's just kind of look at what the last mile is. So essentially, when an AI system starts off, it's basically somebody has an idea, they capture some data, they label, they clean and label that data, they develop a model, and they validate the model. So we have lots and lots of models that are being developed and validated at the moment. but very few kind of in real world implementation and routine use. And that's essentially the last mile, where, like classic kind of digital health systems, it's all about people, process, and technology. We need to, just like any other digital health system, when it comes to AI, we need to kind of take these systems and then put them into our clinical settings and adapt them and make them work. But over and above that, AI has some special kind of issues that need to be looked at as well, because sometimes, a model that is trained on a certain population, it might not be tuned to perform in the population that it is kind of being implemented. So some special tuning may be required. And essentially, even once it's customized and implemented in that setting, if the population or the cohort changes over time, then the model need to be adjusted and over time as well. So we need to kind of be monitoring these models and looking at how well they perform even once we kind of implemented them. So that's kind of, just the challenge of taking AI into our clinical settings. But at a broader level, there are sort of the no talk about AI can be sort of complete without looking at some of the ethical challenges. So let's kind of, the very sort of basic thing here is that we need to kind of start off with it's all about preserving our healthcare values in the first place. So, you're probably all familiar with these basic healthcare values where, healthcare should be beneficent, it should be safe and non-harmful, respectful of individual choices and rights, trustworthy, and equitable as well. So these are kind of universally recognized healthcare values. And so when it comes to implementing AI, we need to kind of, make sure that we're preserving these values, because for a lot of the time, the development and deployment of an AI system may not necessarily be driven by a problem. It could just be because there is lots of data available and you can build a model, and it may not necessarily be for the good of the patient or the public. And so we need to make sure that when we're implementing AI, that it's actually solving a problem that needs to be solved, and it's actually for the good of the patient or the public, and also that it's safe and non-harmful. And if we kind of look at the cycle of digital health kind of implementation and use, we design and build a system, we implement it, and then we kind of use it. It's not a one-way thing. This is sort of an iterative kind of cycle where you keep coming back to modify your design as your use case kind of changes. And as far as medical kind of devices are concerned, the way we're kind of ensuring the safety of AI is through regulation. But essentially what that is doing is medical device regulation just covers the design and build of these systems. It doesn't cover the implementation and use. And this basically, then applies to all of the other classes of AI that we're implementing that may not be regarded as medical device and be subject to regulation. So it's all about kind of making sure that your system is safe, but in design and build, implementation, and as well as use. So there's a key kind of responsibility here that we want to make sure that systems are beneficent and then they're safe and non-harmful as well. There are another number of kind of other broader ethical challenges or ethical tensions that have been kind of described in the literature. And I'm going to kind of talk about them briefly here. So using, algorithms to make decisions and predictions versus, we can have, really high accuracy. So when you're using algorithms to make decisions and predictions, you can have a really kind of high accuracy, but, there's essentially a tension between this and ensuring fairness and equal treatment. This tension arises between, when public or private bodies base their decisions on predictions about future behavior of individuals. And when they employ machine learning to improve those predictions. But these algorithms may not improve accuracy overall. They could, well end up being discriminating against specific groups because you're not, you end up customizing your AI to work really well for particular groups, but it might kind of do that at the expense of other groups. The second kind of tension is between personalization and solidarity. So with increasing kind of personalization. We're tailoring messages to individuals. We're tailoring services to people. So it makes it easier for people to find the right products and services that kind of fit their needs. But we also then end up differentiating between people in such a fine-grained way that then you threaten the social ideals of citizenship and solidarity. The third kind of tension is between quality and efficiency and data privacy control. So essentially, when you're using data to improve the efficiency of services, you collect more and more data. But then, we're collecting data about pretty much every kind of service that we have in the public and the private sphere. But then what does that do to our privacy and our data privacy and control over that data? So how best can we protect privacy, people's privacy, but then also, provide a service that is of high quality and efficient. And then the last tension is between convenience and self-actualization. So using automation to make people's lives more convenient, it kind of makes them more and more empowered. But automated solutions may genuinely improve people's lives by, saving them time and lots of mundane tasks. But then, what have you left for people to do? So you might end up de-skilling people if you're using more and more AI to perform tasks. What's left for people? So that's one of, another question or another tension that has been discussed in the literature. But kind of coming back specifically to health, we're already seeing, that AI can reinforce bias. And here's one example that came up in the literature some time ago. So this was basically an algorithm that was dissecting racial bias. So essentially an algorithm that was used to predict the healthcare needs of Black patients. But basically, it was predicting needs based on previous healthcare utilization. And as a group, Black patients use less healthcare services than white patients. So based on the amount of costs, it was predicting that Black patients were sicker than white patients at that same level of kind of risk. So the risk score that was given to Black people was much lower than to white people at the same level of sickness. So essentially, we're seeing some of these things kind of already playing out, because when you train models on data like cost, where cost is an indicator of utilization, but it's not necessarily kind of an indicator of how sick you might be in the healthcare service you utilize. So let's kind of now move on to the impact of AI on human performance. So the use of AI essentially affects human performance. And a good example to kind of convey this is, your GPS. So basically, automation can make us complacent. So even with simple systems that easily can be verified, we tend not to do so. How often do you kind of sit in your car, turn on the GPS and just go where it takes you? And there may be a number of factors that determine whether or not you might, check that GPS. So this tendency to use automated cues as a heuristic replacement for vigilant information seeking and processing is called automation bias. It arises when automation works well, but not perfectly. The notion of automation bias has been well recognized in healthcare. So here's, a whole bunch of areas, including mammography, ECG, decision support, where the effects of automation bias have been previously reported. So we did some work a couple of years ago looking at automation bias with prescribing decision support. So essentially, it was a controlled laboratory experiment where medical students were asked to complete prescribing tasks, and we measured automation bias. So in the first example graph that is presented on the screen here, we found that, with correct kind of decision support, essentially, there was a decrease in omission errors. But when the decision support was incorrect, there was actually an increase in omission errors. And mind you, this was a simple rule-based system where participants could easily verify alerts. If you look at the other side of the coin and we consider commission errors, we found that when decision support was incorrect, there was a 57% increase in commission errors. So the phenomenon of automation bias has been demonstrated with rule-based systems. And so we can well assume that that will be the case when it's a machine learning based system that is harder to verify. Increasing, with the machine learning system, it's a black box. You can't really easily go into it and check the decisions or the recommendations that it's making. The other effects of human performance have also kind of been well documented and studied. Including mental workload, situational awareness, and then degradation of skills as well. So essentially, the use of automation tends to increase our mental workload. It reduces our situational awareness and can also lead to degradation of our skills. So let me kind of just quickly summarize and finish off. So we've seen that AI or machine learning based systems in clinical decision support. So they provide information, they can assist humans to make decisions, or they can provide decisions themselves. These are kind of 3 levels of autonomy that we've studied. We've specifically studied these for medical devices, but these categories apply to any kind of decision support, essentially, any kind of decision support that may not necessarily be, classified as a medical device and be subject to regulation. We looked at the last mile of implementation and use, and essentially this is an area that needs a lot of attention because no matter how good performing your model is, you need to kind of be able to take it, put it into a clinical setting, and then see what the impact is going to be on care delivery and patient outcomes. We also looked at some of the ethical challenges and said that use of AI should be beneficial and safe as a starting point. And finally, we looked at the effects of AI on human performance. We looked at automation bias and then the other effects on mental workload, situational awareness, and skill degradation. So in conclusion, I just want to kind of flag a couple of things. The first is the Australian Alliance for AI in Healthcare. So this is being led out of Macquarie University, where I work. It's essentially an international membership with national goals. The idea is to accelerate the adoption of AI in Australia and build a community of shared interests. And indeed, we welcome participation from outside Australia as well on this group. It's a community of shared interest and pooled resources. We aim to undertake essential research, build the national workforce, and ensure that AI is safe and ethical in healthcare. The other kind of thing I want to flag is there's lots of opportunities to study in AI in healthcare with us here at Macquarie University. Looking at topics in real-world implementation and operation of AI, the human AI interaction design, AI and resource constraint settings, and then patient safety and ethics areas as well. And so thank you very much. With that, I will finish off. And I thank you for your attention, and I look forward to your questions. Thank you.
Thank you, Dr. Farah. So we have a number of questions in the chat box. So the first one is AI in health regulated in Australia, and how did this develop?
Well, so a small so it depends on the risk kind of category. So some systems, particularly if you're using where you're using software for diagnosis purposes, they fall under medical device regulations. So any AI that is being used for diagnostic and treatment purposes is regulated as a medical device. But the vast majority are not subject to device regulation.
Right. I think Dr. Alvin would like to share something. Hello, Dr. Alvin.
Hi, Professor Farah.
Hi, how are you?
Good to see you. Thank you for accepting our invitation. We have quite a number of people in the call right now. And first of all, congratulations for joining the Academy. We're happy to have a lot of Asians now joining the Academy. I asked the question about the regulation because I think this is emerging, especially in our side of Asia, where the concept is emerging. There's not a lot of groups to form large alliances like what you have right now in Australia, although I think that's a brilliant idea. What would be your advice for governments? I think the commercialization of AI is happening at a fast pace, much faster than how governments can actually understand or get their heads around artificial intelligence. What would be your advice for emerging countries, developing low, medium income countries, where commercialization might be the first encounter of society with AI, and they are not as much prepared to regulate it, if there's such a word, that
Yeah, look,
even if
I
it's
mean, yeah, I guess, people kind of get really scared when you say the word regulation, especially if you're talking to industry and they think you're trying to stifle kind of innovation. So you need to kind of tread really carefully first and foremost. I think it's about being kind of, it's about oversight. It's about trying to ensure that even if there is a commercial imperative to deploy a system, that it's first and foremost, doing something or solving a problem that needs to be solved. I think if you're kind of driven by that, then you're going to address real needs, and so even if it's going to commercially be successful, it's actually going to be solving a problem, so you're not going to be wasting money first and foremost, and you're going to address these important needs. I mean, our health systems everywhere are in crisis at the moment, and we can't afford to waste valuable kind of dollars or any other currency on just deploying an AI system for the sake of it. And so if you're driven by a need, and and it's not only through regulation, but I think there's multiple channels where whenever you're deploying a system, it's either going through, if it's a clinical trial, then it's going through an ethics committee. They can look at whether or not it's being solving a problem. So you have a system being deployed in a hospital. You want to make sure that it's actually going to solve a problem in your hospital, like any other digital health kind of intervention. So you're not just excited by the shiny new technology, but you're looking at what it's going to do. And indeed, there's many examples in Asia where it has, AI has been used to improve screening, to improve diagnostic kind of capability, because we don't have that many specialists and trained people. And so it's solving important problems already.
The oversight is particularly interesting because I guess in Australia, you're quite ahead in terms of the awareness of digital health and information technology. But in smaller countries where you might have an academic here or a researcher there, and they're not even in the position of regulators, and they're just starting their journey, how would you say, for example, the alliance that you formed in Australia? What's the story behind it? Is that something that we should just join? We asked them to join this AI alliance in Australia and build capacity in understanding what it's all about, and then bring back the knowledge.
Yeah, look, that's a fantastic way of kind of doing it. And indeed, we don't have all the answers in Australia. We're actually, learning as we go. But the Alliance is a community of practice, and just being part of that community, you're solving a lot of these problems. And when you talk about capability and kind of know-how, it's going back to your basics. Like we have patient safety kind of governance and committees in every hospital. I'm sure there's some kind of patient safety monitoring and IT kind of expertise in every hospital now, or in every healthcare service. And so AI is kind of coming against that background. It's not coming in a vacuum. And so it's about trying to kind of integrate it with the existing kind of governance mechanisms that you have, however effective or not effective they are. And we don't have it all solved in Australia either. It's very easy to be kind of be distracted by the technology and not look at, is this solving a problem that we need solved?
I think the ethics board is something that's quite familiar already to, even in developing countries, they're starting to form their own ethics boards, and they even form national networks. As a matter of fact, Professor Vajira from Sri Lanka is one of our regional leaders in the network ethics boards, and then they can just follow their ethics process, and then
Exactly. Yeah.
through that process,
Because yeah, I mean the thing is, we're about to do a trial in a local health district here, and they don't have a special process for AI system. It's going to be the same ethics board that it goes through, and it's about us going and explaining to them about what this system is going to do, and them going through it like they would any other system. So yeah.
Are they using some litmus test, like a checklist that you can provide to the ethics boards? Not all of them are AI aware, although they're aware about some
Yeah,
general.
I know that's kind of, I think that's coming, that's something that we would love to design. I think when we do it in one setting, and then, because I would say, none of them, like very few people are really even digital health aware. Like AI is one step too forward, I think. So when you have the basics right, when you have digital health kind of awareness, then you build on that. Yeah.
Okay, I'll call on our chair, Dr. Bunchai Kitsanayotin from Thailand. He's also a member of the academy. Dr. Bunchai.
Okay, thank you, Dr. Farah. I really enjoy your talk, and I really like the idea that we will, as a human, become complacent, and then it's to kind of losing the skill. You can see that we are now using calculator, and it is very difficult for us to kind of calculate a very simple math. They call it in our head. Actually, I really like this alliance, and I think our network should use working with the group, and I think we can working together. Actually, the AI issue, the ethical thing, and also the compression of the government that Alvin just raised the issue. I think this is the kind of the global issue. It's not national or the regional, it's a global. You can see that there is two or three forces that discuss on that. But I think it will go, like you said, we develop and we learn. But to me, I think the data is very important. Quality data will be feeding into the algorithm. And right now, we seem like we don't look very much on data, and everyone are kind of the hype on the technology that they can provide, something like that. So I would like you to kind of discuss about this issue, like the standard-based electronic medical record or something like that. Thank you.
Yeah, look, thank you so much for your question and your interest in the Alliance. I mean, definitely it's worth kind of, joining and learning together. But on the issue of data, look, a lot of like you can see already, the reason why we have so many AI systems in radiology and imaging specialties is because of the data. I mean, imaging data has been structured, there's standards, there's DICOM standards, there's a whole bunch of other standards, and that's why we see so many systems in radiology and imaging related specialties. So even in the review that I talked about, a lot of the input to those AI systems is all images. And the only reason why some of those AI systems were developed because of the data that was available. So imaging is basically clean, structured data that you can feed your algorithms and you can make sense of it. You're not relying on noisy electronic health record data, which I think is what you're talking about. And that's why it's been much harder to have AI kind of or machine learning systems, big, because you need lots and lots of data. You need it all to be in a standard format. So we have fewer systems that actually use electronic health record data. You have more systems using ECG, signals and imaging data. And so I think it's going to take a little while until, even in developed countries, the EHR data is nowhere near as high quality as the imaging data.
Thank you, Dr. Farah. There are more questions here. There's one from Aldilas, and he asked about, and I'm just going through from the bottom to the top, sorry.
Okay.
And what is the Alliance's role in increasing AI implementation acceptance among clinicians and policymakers over there in Australia?
Yeah, look, I mean, basically what the Alliance is kind of doing is, so the multi-pronged approach in terms of the policymakers. So we're talking to government in Australia, the federal government, and then at the state level as well, in terms of just making investments in AI, because we don't have a lot of investment. So first and foremost, to make investments, and then also kind of to provide money for training the workforce at the kind of clinician level. It's multi-pronged kind of approach. I mean, everybody has jumped onto the digital health kind of bandwagon now. So it's much easier than, say 10 years ago. But we need to kind of improve the skills. So it's also about kind of providing digital health and kind of AI training at all levels of training programs, whether it's doctors, nurses, or allied health people. So the Alliance, it's kind of policy making. It's about workforce, and then it's about communities of practice. Where, for instance, if there is trying to assemble small networks nationally of like-minded people trying to do research and kind of helping each other and trying to do studies. So sometimes you might have a clinician who has a lot of data and has a problem they want solved, but they don't necessarily have the machine learning skills, or they don't have access to data scientists. So the Alliance might kind of match them up with the data scientists to kind of help them. So it's that kind of thing. It's basically a community practice.
Like a network, community.
Yeah, it's a network, and trying to join people up.
Right.
The other example is where there might be an industry that is developing an AI system, and they want to implement and evaluate it in a clinical setting, but they don't have expertise to do that. So then, it's about trying to help them find somebody who can do that for them, or do that with them.
I saw some quite, prominent institutional names in the Alliance. Do you only accept institutions, or do you accept individuals over?
Oh, it's both. It's both individuals as well as institutions.
Okay, I think Dr. Bunchay, we will evaluate if the Asian network can join the Alliance. There's a question from Dr. Binchi Pangaibat. He's from the Philippines. He's a doctor. I read somewhere that radiograph readings using AI were more superior than human radiologists. In fact, AI and TB, which you mentioned earlier, will now also be implemented as a global strategy in high-burden countries. Will AI replace some of the specific fields where AI has shown to be reliable and can be applied? And is that a good or a bad thing? Your opinion?
I mean, look, yes, there's no doubt about it that, some AI have shown to kind of be highly accurate, but let's kind of look at it a little bit more, right? It's not the AI versus the human. It's the human unassisted, and then the human assisted with AI. So you still have the radiologist kind of in the loop, who is assisted by the AI. And a lot of these systems, like even in the review that I talked about, none of them kind of say, this is the final decision, this is the diagnosis. All it's doing is it's marking up the image, and then the radiologist still needs to review it and confirm that they agree on those recommendations before they then say, well, these are the diagnoses. So there is a radiologist, there is a specialist or a clinician in the loop for the vast majority of systems. So it's not about replacing them. But we do need to kind of be really careful, because none of these systems are 100% accurate. So there could be areas where it does miss. And so how are you going to train the radiologist to work with these systems? Let me give you an example. So for instance, if you have an AI that is interpreting a chest X-ray, it may be kind of looking at a certain subset of findings. And so the radiologist needs to kind of know, what is it not looking at? And so the radiologist is responsible for that. And even the findings that it is detecting, the radiologist needs to check it because it's not 100% accurate. There's a certain level of accuracy, and so it could miss. So the radiologist basically has the final say. And in the categorization that I presented, the vast majority of these are assistive in that in the indications, it's clearly said that the clinician needs to confirm the findings and report them.
Yes.
So it's about kind of, and when you implement these systems for radiologists, a lot of radiologists say, well, look, it's just having like another pair of eyes checking, because radiologists get tired.
Yes.
They're doing several of these at the same time. So it's about having that buddy to assist you rather than replace you.
And they take final accountability.
Yes, they have to take, yes, because according to that's the basis on which it's regulated and being marketed, right? The clinician is accountable.
Has it occurred in Australia where the radiologist conflicted with the advice of the AI and it became an issue?
Well, I mean, I know, look, I haven't heard of anything publicly reported, but just from talking to people, I know when the systems are not perfect, there are certain AI that, like certain findings where the radiologists have disagreed with the AI.
Correct. Yeah.
And so then, there are a few studies coming out now where they've actually used AI in radiology settings, and then for a certain percentage of cases the radiologist has disagreed with AI.
I actually can share some kind of story in Thailand about the AI for diagnosis of TB, tuberculosis, and it's very surprising that the developer, which has some doctor inside it, using kind of the 2,000, maybe 10,000 image, and then developing the AI, and they are the Ministry of Health are advertising that it could help kind of detect the tuberculosis case. I mean, in the fields, and the story is that when they try to implement that in across the country, and sometimes they have a case that is very the clinical findings maybe not comparable with the X-ray that the AI say that it's possible or very likely to be TB. Then they go to the physician, maybe general practice or the medicine, to ask them that why is this the patient the TB? The reaction of the doctor is that, oh, I will not give you the answer because of if I wrong, then I will accountable for that, and then there will be a lawsuit that the AI already said that it's a TB, and I said not the TB. This one is one of the, I think AI should be augment the decision of the clinician in all level, and the accountable should be the physician. But right now, sometimes it kind of the advertise too kind of the too good. Then people afraid, even the clinician afraid that if they give some kind of the advice or diagnosis, then they will accountable for what they diagnose it. If accidentally he is wrong, the physician is wrong, and that's why the maybe the regulation and also the guideline how it works.
That's like AI is preempting the human diagnosis.
Yes.
Yeah. We have a lot of interesting links in the chat box, so you might lose that. So please don't forget to click on it. I shared one on the WHO guidance on the governance and ethics of artificial intelligence, and Mike Bainbridge shared some resources. Mike, do you want to explain what you posted?
Thank you, Alvin. That was very good.
Yes, sir.
Thanks, Alvin. Just to shamelessly plug this, which is out of focus because of the blur, it's the ADB Digital Health Implementation Guide for the Pacific, which I've been working for the last year with the team in health there. So it's a Pacific-centered guide, but if you discard, or not discard, but take into account that all the case studies are in the Pacific, what they are espousing is a very simple structure which is of global significance. So 3 big things: leadership and governance, technical, and analytics and innovation. And taking on board all of the structure that Farah has offered us today, all of this must underpin it, because if it doesn't, we just end up with an interesting project in one place which will give us something interesting, but we want change. We want universal care, we want affordable care, we want safe care, and all of that needs leadership and governance, technical standards, and analytics and innovation. And the links in the
that's why
the
you
chat.
have to come back. 3 minutes is not enough for that, Mike. You have to come back for like an hour of that.
Okay, it's a deal. You can see me blushing. I should have got back to you.
Nice to see you, Mike.
Actually, Michael, we already distribute that report to our network, and we really appreciate that you mentioned the artifact that our network has been done for the last 10 years. The convergence, which is related to the leadership and collaboration, and also kind of the several things, and that means that we can work together and then make it more. And I agree with you, just taking out the Pacifics, and then it can be global.
Yeah.
And that to me, I agree with you that it suits several contexts, and that frameworks, 3 of you, and the gaps that we define the infrastructure is the one that it really need for the digital health development in, to me, not just the region, but in the world.
Yeah, absolutely. And
Mike,
yeah.
we'll be back. We've reached the top of the hour and it's late in Australia. Dr. Farah, any advice to a network like AHIN? We are a network of government and academic and non-government organizations interested in e-health, especially artificial intelligence. What is your advice for governments specifically?
Well, it's kind of about, I mean, look, I'm an academic, so my interest is, provide more money for educating people first and foremost, educate the next generation, because we need to be training our workforce. And then more money to kind of actually deploy and test these systems and look to see where we can, where is the pain in terms of how can we most effectively use them to solve the important problems that we're facing in our health system. So yeah, research and training.
Thank you very much, Dr. Farah, and I hope we can
Wonderful.
invite you again in another session. And to everyone, thank you and good night. We'll see you again in
Thank
another.
you. Bye. Thank you
Wonderful.
very
Thank
much.
you so much.
Thank
Bye.
you.
Thank you.